if the sound's unclear at any point, please just interrupt and ask, because I don't want you to miss everything, although most things are on the slides as well. Welcome to today and to New Zealand. I'm also relatively new arrival to New Zealand. I moved in 2020 from the UK, and I had to do some other bits to my pharmacy training as well, so I kind of understand what it's like to have to go through different things. So for the next sort of hour or so, I'm going to go through some things on medication safety and also some sort of medicines related legislation and scope of practice. Firstly, I'd like to thank Rob Ticehurst at Auckland for sharing his presentation. So I believe he presented last year to you. So, sorry, moving my slide forward too much now. And quite a lot of the presentation I've used is his slides, so I have to acknowledge him there. As I said, I'm going to talk to you a bit about medicines related legislation and scopes of practice, and then a bit more on medication safety and things like errors and how we prevent them. I just wanted to know, to start with, does anyone have any sort of specific questions or issues in relation to any of those things that they were hoping would be covered this afternoon? It doesn't matter if you don't, but has anyone got anything specific? Okay, well, I'll just keep going, but we're a fairly small group, so feel free to interrupt either in the chat box or just to talk at any point if there's anything that's not clear or not covered or anything else you want to know. I think Balaji's going to probably give you a copy of the slides at the end, so you'll have all those, and I've got my email address as well, so if there's anything that's not clear or you want to follow up or you want to know more of, then you can always do that afterwards. So I've just got a couple of questions to start with about some of the legislation and groups in New Zealand. So this first one is which group was established in 1993 in order to get the best health outcomes for New Zealanders from within our budget by obtaining better value for medicines. So does anyone know what this group is? So this is Pharmac. So they're our national organisation that's sort of worked, use the buying power of the whole of New Zealand really to get best value for the medicines. So they're able to get good deals and buy things because they're buying for across the whole country. It's quite a different model from what I was used to in the UK, so it might be different to what you're used to as well. They started with list of medicines, with cancer medicines, national immunisation schedule. They've got a hospital medicine list, which we use all the time. That sort of tells us what we can have in hospital, what's funded. And they're also updating a list of hospital medical devices as well. And then we've got another group that's responsible for the regulation of medicines and medical devices in New Zealand and for ensuring that these are safe, basically meet acceptable safe limits. So does anybody know what this is called? Anybody know or want to have a guess? No. All right, so this is MedSafe, who you may have heard of. So they're accountable to the Ministry of Health, and they administer the Medicines Act and the regulations that come with it. So they regulate products used for therapeutic purpose, so things for the treatment, diagnosis and prevention of a disease, or something that modifies a physiological function. And they also include contact lenses for some strange reason, contraception and anaesthetics. So they include medicines, as you'd imagine. Oh, sorry, I've just seen someone's typed MedSafe now as well. Sorry, I didn't have my chat open at the time. So yeah, thanks Balaji for replying. So MedSafe, obviously medicines are the main things that they regulate. They also regulate related products, so things like throat lozenges and fluoride toothpaste, medical devices as well, so dressings, heart valves, and also controlled drugs when they're used as medicines, so things like morphine as well. So there's different classifications of medicines, which you may be familiar with. Prescription medicine is very much as it sounds. It's medicine that's only available on prescription. In New Zealand, we have restricted or pharmacist-only medicine, which means it's only available. It's not on kind of general sale in the pharmacy. You need to ask for it, and it can only be sold by a pharmacist. So these include things like a short course of trimethoprim for a urinary tract infection. There's also pharmacy-only medicines which need to be sold in a pharmacy. So they might be things like large packs of paracetamol, so rather than just the small packs, big packs of paracetamol. Also some certain types of things for like hydrocortisone cream, certain types of things for fungal infections. We also have general sale medicines, which are your things like the small packs of paracetamol that you can pick up in the supermarket. And there's also controlled drugs, and they have different classifications as well, which we don't really need to get into. And the way to find out what classification that a medicine is basically to look in the New Zealand formulary, which is readily available online, and it tells you which class that medicine belongs to if it's something that you need to know. So what? Well, different classifications can have things like different storage, different prescription requirements, and some controlled drugs need to be recorded in a register as well. So sometimes you may need to know what class of medicine is. I've got a medication chart versus prescription on there, because what we tend to see used is medication charts in a sort of hospital setting. So that is a chart obviously with all the patient's details on it, with individual prescriptions on that medicine chart. So we also have section 29 medicines, and those are things that are not registered in New Zealand. So they are registered in another country, and quite often it will be Australia or the UK, but they're not registered here in New Zealand. But they're allowed to be used under this section 29 of the Medicines Act. And it just means there's some slightly different requirements around those. They're only able to be prescribed by medical and dental prescribers, and the patient needs to consent. They need to be informed that you're going to use a section 29 medicine for them. So that's the prescriber's responsibility to make sure that they consent to that, just because they're not registered in the country. We also work with standing orders, and we do that quite a lot within the hospital. And that's a way of administering or supplying medicine by someone that's not a prescriber. So it's often nurses, but there's also paramedics within the hospital setting that are able to do that. And also some hospitals use pharmacists to work under standing orders as well. And they're very much about enabling timely access to medicine. So they're used quite a lot in the emergency department. So it could be for something like a single dose of IV morphine, where a patient comes in, they've been triaged, they're waiting to be seen by a doctor, but they need some sort of pain relief in the meantime. And the standing order allows someone to give a dose of that without it being prescribed for that patient. The responsibility very much lies with the issuer of that standing order, which is usually the clinical director. And the individual using the standing order. So if you're using it, you need to be happy with what's in it as well. And it also needs, because it's not a prescription, it does need to be signed afterwards or audited as well. And those are sort of Ministry of Health requirements. So we're a bit stuck with those, but they are useful standing orders, like I say, to give medicines in places where you're not immediately able to have a prescriber present. I don't know, Balaji, would the renal physiologists ever use those? Would ever use a standing order? Do you give anything under a standing order ever?
We currently have only one, which is a normal saline for hypertension management for patient. And that's the only standing order we have. Rest of them all prescribed.
Okay, so it's something that you're familiar with that I guess you could use in other situations as well. Yeah. Okay, thank you. I've got a little paragraph on dispensing, and this is a funny one, really. I think it's similar in other places, but it just means that no person other than an authorised prescriber, a vet, or any sort of pharmacist or student is able to actually dispense a prescription medicine. So we just need to be careful if we're giving out things from a sort of ward or a clinic setting that we're not actually dispensing it. But most of the time, things that you'll be giving sort of are covered under administration. And the legislation allows anyone to administer medicines, including controlled drugs, as long as they do so in accordance with the directions of the prescriber or with the standing order, which seems to make sense. Again, in some countries, legislation only allows certain groups of healthcare professionals to administer medicines, but here, as I say, it allows anyone to administer it, as long as they do so within the directions. And then all people who administer medicines must be familiar with the policies and procedures about medicine administration, which I guess makes sense, but it just means if you're moving to a new, even though we're all part of this great big health system now, we obviously work within different regions and different hospitals and different settings. So the medicine administration policies and guides may just be slightly different depending on where you work, even though they're within the framework of the law. There might be some slight differences, so just kind of be aware of that if you're moving around. So the present and the future. So there are non-medical prescribers starting to come through. There's a lot of nurse prescribers. There's also a smaller number of pharmacist prescribers, and we also have dietitians who are able to prescribe. In other countries, there are wider groups able to prescribe, non-medical prescribers, so physiotherapists, for example, radiographers, which are the imaging technologists here. So I think we will probably start to see that group grow, but quite small, but quite slowly, the non-medical prescribers in New Zealand. There is an update to the Medicines Act and regulations in the pipeline, so it's going to be called the Therapeutics Product Bill. It's had its first reading in Parliament, but it's not going to be brought into sort of legislation until I think 2024, but you might hear updates on that and things about that. And it's going to, the idea is it's going to be easier to understand and kind of be updated a bit more from the 80s when the Medicines Act was first written. So any questions on any of that so far? It's not the most exciting topic for a Friday afternoon, I'm afraid. But hopefully the kind of basics are there for you, and if you do need any more information, then just feel free to reach out and ask. Just look in the chat. So what do you mean when you say medicine is registered in New Zealand? So MedSafe are the organisation that register medicines in New Zealand. So if you had a medicine that you'd manufactured and wanted to bring into New Zealand, you have to apply to MedSafe for a license, basically, for that medicine, to make that medicine licensed in New Zealand. So each country does the same thing. So you might a medicine might be licensed in Australia, New Zealand, America, UK, India, China. Each country has its own process for licensing a medicine. So that's what I mean by that. And just because a product is licensed in one country doesn't mean it will automatically be licensed in another country. And because we're quite small here in New Zealand, we often do license things or register things slightly later than other countries, which can be good because it means that other countries seem to do a lot of the work for us. So with some of the COVID medicines, what we found was that they would be registered usually in the US or the UK, where they were using lots of them. And then in New Zealand, we would use them as a sort of Section 29, not registered in New Zealand product, before MedSafe approved them. So hopefully that answers the question. I guess there's different, depending on where the product is registered, depends on how much of an issue it is for us. So as I said, lots of the products we use might be registered in Australia, which means that they're in English. The packaging usually looks very similar. So they're, in terms of sort of a safety perspective, they're pretty much, we're happy to use them. What we might have though is a product that's not registered in a English speaking country, so might not be, the packaging might not be in English, the name of the drug itself might not be in English or might not match the name that we use for it. So then there's sort of slightly different concerns about the safety of using it, and sometimes we label those over the top in pharmacy with the label and the dose strength in English. So hopefully that's answered that question, but just yes, thank you, good. That's okay, yeah. Okay, so any more questions, just I'll try and keep an eye on the chat, so feel free, or Balaji, maybe keep an eye on that for me, but feel free just to kind of type in or speak up if there's anything else. So I'm going to talk for the rest of the session on medication safety, which is a huge topic really, but I'll just cover a little bit about it and just hopefully give you a bit of information, and I think this is slightly more interesting than the legislation, so hopefully it'll be a bit slightly more engaging for you. So I'm going to talk, this is just what I'm going to go through for the next sort of 45 minutes probably. So the 5 rights, hopefully you've heard, or you may have heard of the 5 rights of medicine administration. Can anyone either call out or type what any of the rights are?
Right patient, right drug,
right patient, right drug,
right dose,
yeah,
right time, and
right
route.
time. Yeah, absolutely, perfect. So you know it. Let's see what order I've got them in. Yeah, so right patient, medicine, time, dose, and route. Any others? Can anybody think, has anybody heard of any others? Those are the key ones. Sometimes they talk about the right reason, so the right reason for giving a medicine, the right documentation, so making sure that you record it as well, and the right response as well, so ensuring the patient has the response that you're expecting to that. So sometimes you'll see 7 rights, which includes another couple as well. Are there any problems? Well, what are the problems, or can you think of any problems with the 5 rights? So the thing, oh, someone's in the chat. So you have a look. Right reason. Okay, I've got those. Thank you. So the problem with the 5 rights is they very much rely on the individual that's giving the medicine, and they're not thinking about the system or the culture that they're working in. So they are important. It is obviously important to give the right patient the right medicine at the right time and in the right dose and via the right route. But but how is someone supported to do that? So you're supported to identify the right patient because your organisation says that they should be wearing an ID band. You're supported to give them the right medicine because it's been correctly labelled by pharmacy, and it's somewhere that you can access it. It's in a locked cupboard or somewhere that you've got access to it, and it's got the correct label on. So whilst the 5 rights are important, so is all the sort of organisational and system and culture around that supports people to get it right as well. So that's what we're going to have a look at as well when we look at medication errors and when things go wrong. So medication error is any preventable event that may cause harm. Oh, right, I've just got a question. Some medicines can be bought over the counter in some countries, but in another country it only comes as a prescription, e.g. pantoprazole is the question. So yeah, and that's a good question, and it just comes down to the licensing and in that particular country. So you might find that one country decides that it doesn't need to be a prescription medicine, whereas another country decides that it should be a prescription medicine, or it can be a pharmacist restricted medicine. So that's just it's decided by the country and the legislation in that country, and can be quite hard to keep up to date with if you move with what's going on in each country as well. So it is just down to the licensing body, so that's MedSafe in New Zealand, to make those decisions. I guess they just look at all the evidence and what they think is best for possibly their cohort of patients in that country, and make their decisions based on that as well. So the medication errors, the most common ones I think we think of are around prescribing and dispensing and administration, but I've also got there are lots of other things, so communication, labelling, monitoring, education, compounding or reconstitution of a medicine. Lots of places it can go wrong. Medication errors are among the most common errors in a healthcare setting and a leading cause of patient harm. And this study in New Zealand around the end of 2018, 2019, showed that around 28% of inpatients suffered medication-related harm. And that's a huge number, isn't it? That's like a third of patients in a hospital setting are suffering from some medication-related harm, which is not really what you expect when you go into a hospital setting. 44%, so almost half of those serious events, so the ones that led to disability or death, were preventable, which I think is good because it means that we can do something about it, but also bad because we haven't done something about it. But it means that we can, they're not just things that happen, they are things that we can do something about. So the types of errors, I've sort of call these human errors, which is around the environment, the team or the task. So, are you more likely to make an error because the air conditioning is broken and you're working in a unit that's got a temperature of 30 degrees, or you're very short in your team, or you're just doing a very complicated task. So you're working out a complicated equation, a calculation, or measuring something or reconstituting something complicated. You're possibly more likely to make an error. Systems errors are the ones around the organisational process or the culture. Did something go wrong because you were asked to follow a procedure and you couldn't find it, or the computer was broken, or there was no computer in the room that you were using? Did something go wrong because of the culture that you in your organisation? So you tried to speak up and say that you thought something was wrong, but nobody listened to you. In reality, a lot of errors involve some sort of human error and something to do with the systems as well. And we'll just go through the different ways we can help with those as well. So I've got a couple of clips to show you, which I hope are going to work. But let me just see. Going to take my headphones out. So I hope this is going to work. Can you still hear me okay?
Yes.
Yeah, okay. And can you see, yes, good,
YouTube
okay.
video.
So you should be able to see a YouTube clip on the screen now, hopefully, which I'm going to show you. It's just a few minutes long. It's a reconstruction of a plane crash. So in healthcare, we've learned quite a lot from errors that happened in the aviation industry. So I'll let you watch that and then we'll catch up after. There are subtitles as well in case it's hard to hear or in case your audio is not working very well.
Black box data leads investigators to
These guys.
investigators now suspect
Okay, so that was obviously a reconstruction done for YouTube, but it was a real plane crash, a Korean Air plane crash that crashed and killed everyone on board. It was a cargo plane, so it was only the three people there in the cockpit. Like I've mentioned before, the aviation industry have done a lot of work with errors. Obviously, people make errors when they're flying a plane. They can be fairly catastrophic. They've done a lot of work on sort of systems and culture. You'll have heard some of the language they use there, where the first officer was afraid to speak up, and they have what they call a cockpit hierarchy. And that's something that we do see in healthcare. You probably have come across it or will come across it at some point, where you've got that hierarchy where often in healthcare it's the doctor in charge or the consultant that's in charge, and they're the ones that are assumed to be correct, and sometimes it's hard to question them or challenge them, and the culture hopefully is changing, that people are able to speak up when they think things have gone wrong. But this is a real life example. It's albeit from about 40 years ago, where the conclusion was that the crew didn't feel they were able to speak up and challenge the captain, even though they thought something was wrong and those alarms were going off, but nobody was responding to them. So I'm going to show you another clip now, which is a bit more, well, it's more healthcare related. And I'll just let you have a look at this, because it explains what we call human factors, and explains it much better than I can. So I'm going to let you watch this. The sound is quite quiet on here, so I put the captions on, so even if you can't hear it clearly, hopefully you'll be able to see what's being said.
Back in 2005, my then wife Elaine went into hospital for a routine operation. Sadly, she never regained consciousness, and 13 days later she was dead. I simply wanted to understand what had happened, but as an airline pilot, I had a slightly different perspective on how we learn when things go wrong. Eventually, I was granted an independent review, which identified that there were issues all around the science of what we call human factors or ergonomics. I should say that human factors and ergonomics are interchangeable terms. In essence, it's about how we design the system to make it easy to do the right things, and it's about how we behave in a way that makes colleagues to do the right thing.
Sorry, I think that the weather's playing havoc with the internet. Okay, I think we may have lost that. Yeah, okay. We've lost that, but we'll go back to the presentation. So that talk was by Martin Bromley, who's an airline pilot, but his wife died during a routine operation in the UK. And the sort of review of it was that things had gone wrong due to human factors, and human factors are designed as aspects of being human. So as you'd expect, such as our ability to process information, make decisions, communicate and adapt to situations that either help or hinder people to perform their job safely. And the key thing that he says, which I think is really important for us as an organisation for thinking about making things safer for our patients, is that systems should make it easy to do the right thing and conversely hard to do the wrong thing. So thinking about labelling of a medication, it should be easy to pick the right medicine. The writing on it should be clear. It shouldn't be very similar to a medicine with a different name or a different title. It should have clear labelling, so it should be easy to do the right thing and hard to do the wrong thing. And human factors encourage us to learn from success and failure. So encourage a just culture, which I talked a little bit about with the airline industry. So a just culture is where people feel it's okay to speak up if they think something's wrong or something's going wrong. So that might be a particular event that they're involved in, or it might be something that's ongoing. And it ensures that mistakes are not repeated and success is. So error reporting then. So why should we report errors? Why would you, if you're involved in something where you make a mistake or a colleague makes a mistake, why would you report that? What's the advantages of what's an advantage of reporting it?
Because to identify causes of the mistakes and to rectify the issues and to solve it, so it will be easy to prevent the errors in future.
Yeah, absolutely. So reporting, analysing it is fundamental to stop it happening again, isn't it? So it also, excuse me, resolving the issue that you've got, but also looking at preventing it happening again. So if you can identify an error, you can look at the root cause, or that might be lots of different causes, which might not always be the thing you think, and then it enables you to take preventative action. It includes near misses, so it's good to report near misses. Yeah, sorry, someone else has put in the chat, to reduce the effects of errors and prevent them. So yeah, absolutely. So prevent them happening again. So do you know how to report a medication error at your workplace? If you were involved with one, would you know what to do?
Yeah, we have like in the panel we will be having incident report.
Yeah.
So we'll be going and documentation the reasons for the incident.
Okay.
And informing to the coordinator and the manager.
Yeah.
Yeah.
Report.
Sorry, was someone else talking?
Yeah, the medication error report.
Sorry,
medication error report.
A medication error report. Yeah. Sorry, I couldn't hear that very well. But yeah, hopefully you know how to report a medication error at your workplace. If you so at Waitemata we have our instant report is called RL6, and we can find it on our intranet site to report an error. There will be differences across the region. Some places they're called a risk pro, and everyone should be able to report them. So if you don't or you're not sure, it's good to go away and try and just find out if you ever need to do it, how to make that report, or who to ask for help. And what are the barriers to reporting? Why do you think people don't report errors? Fear, yeah, absolutely. That's probably the biggest one, isn't it? Fear of you know, getting into trouble, or you've done something wrong, or reporting it. What else do you think would prevent you from reporting an error? I guess there's time. If you ever tried complicated reporting systems, yeah, absolutely. So that's just what I was about to say. So if you've ever done one, then it's not just a 2-minute job. You do have to put in quite a lot of information, so that can definitely slow people down, and the time it takes to do that, especially if you're looking after patients, then you think, oh, maybe I'll do it at the end of the shift or the end of the day, and then you're going home and then it's the next day. So yeah, so I think definitely, I think probably fear of getting into trouble, or getting yourself into trouble, or getting a colleague into trouble as well. Sometimes people say they don't report because nothing ever changes, nothing ever gets done about it. Won't make any difference. I know why it happened, so what's the point in doing a report about it? So that can sometimes stop people as well. Yeah, fear of facing legal consequences, absolutely, if you think it's something that you've done wrong. So it's very easy to say, like, let's report things, let's be honest and open, but we know in reality it is quite hard, and it's quite hard. We hope we're working towards a culture where it's okay to talk about making mistakes, and to look for to support each other to do that, but recognise that it is harder to do in practice. I've got a couple of slides on terminology, which aren't very exciting really, but there's near-miss events, which are, as they sound, errors that don't reach the patient. There's also something called a severity assessment code, so you might sometimes hear this when people talk about errors. They go, and these are produced by the Health Quality and Safety Commission, the HQSC. You don't need to know them when you go in. If you go to report an error, it will guide you around this as well. But basically, SAC1 is the worst. It's severe, so death or permanent severe loss of function. And then SAC4 and 5 are the minimal ones that, so they include near misses. There's also some always report and review events, which always have to be reported, as well as being reported to your hospital. They then have to report to the Health Quality and Safety Commission. So these are things like wrong site or procedure, wrong intervention. So that's like if you go to radiology and they x-ray your left shoulder instead of your right shoulder. Wrong consumer or patients, that excludes medicines, which is good, otherwise we'd be doing it all the time. And discharge to the patients and things and children to the wrong family. So there's a few there that just that's just some terminology you might hear as well. So ways to reduce errors. One of the things we do, or we can do, is electronic medicines management systems. So some of you might work with electronic prescribing and administration. There's also things like clinical decision support when it comes to prescribing, that gives you options of things to pick, drop-down boxes. Automated medication dispensing. So if you work within, some places will use the Pyxis machines that you get medicines out of. Some places will have like a robotic dispensing machine. So there are all ways that the errors can be reduced, and policies and procedures I've got in there as well. I've just got a few pictures to show you really of how of some things that can go wrong. So can anyone see a problem with that box at all? Something that could possibly lead to an error in the labelling. just shout out or type in if you can. I'll move on quite quickly just to so I don't keep you here all afternoon on a Friday. So this has got like trailing zeros in. So sometimes if people look at this, if you looked at this with from a distance, it could look like 2000 milligrams. There's no real advantage in having 2 zeros after a decimal point for something like 20 milligrams. So and depending on how it's written as well, can just be a bit confusing. So it's kind of not best practice to have what we call trailing zeros. Doesn't add anything. So this one, sorry, these are very blurry. Any potential problems with these two medicines? They're similar but different. So this one, it's just highlighting that the strengths are different, even though the box is exactly the same, which is not uncommon really, is it, to have the different strengths. They've also got trailing zero. So again, if you kind of squint or take glasses off, it might look like 10 and 20 rather than 1.0 and 2.0. So again, just potential for picking the wrong thing. This one really is blurry. It's not your eyes. This is vitamin A liquid for children, and this one's tricky, so I'm just going to show you the next thing. So the dose on this one is 1 drop, but the dropper that comes with it measures in mils. So you could we've seen errors where people have measured 1 mil and given 1 milliliter instead of 1 drop. Obviously 1 drop's like is literally 1 drop, but they've created a dropper which says 1 mil, which is pretty confusing. So again, in terms of like, although it might result in someone making an error on the front line, the system is not fit for purpose, is it? It's not there to support us. So even though you're doing all your rights, the system here is setting you up to fail. It's setting you up to look at one and measure the wrong amount. So these are things that we can do to you know, help people get it right, basically do the right thing. This one is an error that was missed. It's a bit more confusing, but there was a change of product, which happens all the time, especially with COVID. We've had lots of issues with our supply chain. So the strength of this ketamine is 100 milligrams per mil. And if you can see, that's what's on the vial as well, but they're actually 2 mil vials. So what happened in this case was that they used to keep 1 mil vials, and we were then able to get in 2 mil vials, and the patient was given the whole vial, so they got a 2 times overdose. And again, it's just not very clear labelling to say 100 milligrams per mil. It's 200 milligrams in 2 mils is the amount that you've got in that vial. So learning from incidents, every instance an opportunity to learn, be it just the person that made the mistake or wider. The minor incidents are useful as well. We shouldn't forget the things like the near misses. And you know, if we don't look for opportunities to improve, we're doing a disservice to our patients, and we can't fix things if we don't look for opportunities to improve. And share the learning. So I'm just going to share with you an error that I was involved in looking at, where something went wrong and it wasn't necessarily exactly as it seemed. So this is a real patient. It's an error that happens in Waitemata, and it went to it was reported to the Health and Disability Commissioner because it was a serious event. So the learning is able to be shared as part of sharing, but the obviously the patient details aren't there, and it's obviously kind of it's confidential in that please don't go around telling everyone, oh, Waitemata made this error where they gave the wrong midazolam, but it's fine to use for your own purposes and your own knowledge, and you can share it with with colleagues as well. So this patient was prescribed midazolam 2.5 to 5 milligrams subcutaneously for anxiety, agitation or respiratory distress, but they were administered midazolam 5 milligrams intravenously, and they actually passed away shortly afterwards as a result of this error. They were a palliative care patient, but the medication error hastened their death. So I'll just run you through what happened. Patient was admitted to hospital on what I'm going to call day 0. They had a severe illness and were under palliative care, and it was unclear at that stage whether they'd survive the night. So they were prescribed fentanyl IV, oxycodone oral and subcutaneously, and midazolam subcutaneously. So sort of medicines for treating their symptoms in the last hours of their life. Overnight and day 1, they actually rallied and seemed to be doing a bit better. So the fentanyl and oxycodone were stopped, but the midazolam was left on the prescription. So I should say that at Weta we use electronic prescribing. We use MedChart. So once something's prescribed, it stays on there until it's taken off. Patient was then prescribed some oral analgesia, so oxycodone prescribed regularly, with some IV oxycodone prescribed if they needed it. So days 1 to 11, the patient received oral pain relief regularly. It was stopped on day 11 as they were thought to be drowsy, but possibly had an ileus. And the intravenous oxycodone was given between day 1 and 7. So days 11 to 14, they weren't given any opioid analgesics. They were given regular paracetamol and pregabalin. There's lots of information because it's quite detailed investigation, but I'll just focus on the bits that are important. So day 15 at 9 o'clock in the evening, they were given some IV oxycodone because they seemed more uncomfortable than they had been. So the next day, in the early hours of the morning, they were still uncomfortable and given some more oxycodone. Just around an hour later, still seemed agitated, so they were given midazolam IV, which was prescribed as subcutaneous. They were given 5 milligrams intravenously. So what went wrong? Well, at first look, it's human error. The nurse gave midazolam intravenously rather than subcutaneously, so they picked the wrong route. So they got one of those 5 rights wrong. But we know it's about more than that. We know it's not just somebody. We know if somebody gets it wrong, it's that usually because the systems and processes aren't in place to support them. So the patient had IV access, and obviously they could have had subcutaneous access as well. So there was a choice of routes. The patient had midazolam prescribed for them, and the midazolam was prescribed at a range of 2.5 to 5 milligrams, giving the nurse a choice of doses. So where could the error have been prevented? The midazolam prescription could have been reviewed. I've mentioned that they were prescribed it for their sort of final hours or day of life, and 16 days later it was still on the medicine chart. So is there something we could have put in place that would have stopped this, an automatic review or a stop, or something that could have flagged up to say, does the patient still need this 16 days later? So one of the possible disadvantages with electronic prescribing charts is that, unlike a paper chart where people tend to look at them physically every day, they don't always scroll through them every day. And also paper charts had to be rewritten after 14 days usually because the paper would run out, and that doesn't happen with electronic charts. The patient's IV line could have been removed. They'd had no IV medicines for 7 days, but they still had an IV line in place. And the patient could have been prescribed, instead of a range, they could have been just prescribed 2.5 milligram. They were a frail elderly patient, so they could have been prescribed just a single dose at the lower end of the scale. So what changes did we make as a result of this error? So we put another option on MedChart, our electronic prescribing system, as a quick list, which is actually midazolam 1.25 milligrams, so a very small dose for frail or elderly patients. We've updated MedChart as well to capitalise subcutaneous and also intramuscular, so the less commonly used routes of parenteral administration. So it's a bit more obvious that the nurse reported in this error that they just didn't see subcutaneous and they just assumed it was intravenous. So we've looked to try and make it a bit more obvious. And there's also, into the palliative care policy, there's also an addition of some information about the subcutaneous route being safer. And when prescribing subcutaneous midazolam, consider switching other medicine, especially IV opioids, to the subcutaneous route as well. So in this case, if the patient had had subcutaneous opioids, there wouldn't have been an IV line in place. So the nurse would have been physically unable to give the midazolam intravenously because the patient wouldn't have had an IV line. So hopefully that's just shown you that things aren't always as they seem. It's not always, although an error seems to be very much, well, this person got it wrong. They did, but why did they get it wrong? And what systems can we change and make better to support them so that they makes it easier for people to do the right thing? And that's what we're always looking at. This triangle really just shows it's telling us that the systems related functions are more effective than human related functions. So in terms of reducing errors, forcing functions are more effective than education and training. So if MedChart had just after 14 days said this midazolam is no longer needed and stopped it, that's a forcing function. So things that force people to do things, to make a decision, to press a button, we know are more effective. The same with automation and computerization. So electronic prescribing and administration and supply, we know are effective at reducing errors. We know that actually the human related things are less effective. So we talk a lot about education and training, but actually in terms of reducing errors, they're kind of way down there. The same with rules and policies, and reminders and checklists are slightly more useful. But those forcing functions, so the things that stop people doing things or make them do something, along with automation and computerization, we know are the most effective. So I'm almost finished. I've got one slide on double checking, independent double checking. So is this something that people are familiar with? Anyone heard of this before? Or is this something that you do? Do you have double checks on the drugs that you administer, some of them or all of them? So certainly intravenous drugs normally, let me open up the chat. Yes, all, yes, yes, yes. Okay. So all your things, okay. And any downsides to double checking? Does it work? Do you think it helps? It works, so no downsides, it works. Yeah. Anyone think it doesn't work or? Oh, it works, but hard during busy shift. Yeah, absolutely. And it works. Yeah, good. So it absolutely should work, shouldn't it? Because you've got two people checking rather than one. Oh, sorry, just scrolling through all my slides now. Yeah, it absolutely should work. The time it goes wrong really is if you it's not an independent double check. So if someone prepares something and then says to you, can you just check this, and you know, or can you just check that that's 10 milligrams of morphine? So they're telling you, or can you just check that's 10 milligrams, I need to give 10 milligrams of morphine, so I've drawn up 1 mil, is that okay? So someone's telling you what you think you need to know. So the independent double checking is very important, because it's starting the process, starting from the beginning. I won't bore you with it, but there's a lot of research and stuff on double checking, and some people think it actually doesn't work, but probably because it's not done properly. So if it works, and you must be doing it properly, and that's good. These were from Rob's slides, so I've left it in. It's just a sort of acronym to help you remember some of the high-risk medicines, and it's called APINCH. So it stands for anti-infectives, potassium, insulin, narcotics, and heparin. And errors are not necessarily more common with these medicines, but there's a greater risk of harm. So these are the ones that we do see coming up again and again, where things go wrong and they can cause more problems. So I'm just going to wrap up really by sort of sharing some information sources. So the New Zealand formulary, hopefully you've all seen and you're all familiar with. It's great because certainly in the UK we had a formulary, but you had to have an app, or you had to have access to it, whereas the New Zealand formulary is available on the internet to anyone, anywhere, at any place. So you can get it on your phone, you can get it at home if you want to. So it's really good. It's basic, but it's really good information. I use it all the time. It's got information on all licensed, but also some Section 29 medicines as well. It tells you, it will tell you what class of medicine that drug is, if you want to know whether it's a controlled drug and you're thinking, oh, do I need to order it on a controlled drug requisition, or do I need a double check? It'll tell you that. It's got an interactions checker, so if you want to check whether something interacts, it directs you to the next bit down, which is the MedSafe company data sheet. So if the drug has got a data sheet, it will have a link to that on it as well. So really, really good place to start for information. So MedSafe, as I said, have got the data sheet. So this is the company information that kind of they have to do from their regulatory process. And that gives you more information than the formulary. So if you were writing a standing order and you wanted to know all the contraindications for a particular medicine, or all the possible side effects, or a patient comes to you and they've got a side effect that's not in the formulary, there's more information on the data sheet. And then Pharmac, that I mentioned at the beginning, that will tell you about the funding status or the hospital status of the medicine. So if you want to know whether it's funded, that's quite a unique model to New Zealand. That's something I wasn't familiar with before I moved here, and I still often forget that I have to check if things are funded before we're allowed to give them, or whether people are allowed to have them. So again, that's just a useful website to have in the back of your mind, really. Pharmacy support, so depending on where you work, you might have a ward pharmacist, you might be lucky enough to have a renal specialist pharmacist. Again, depending on if you work as part of a larger area, you might have a medicines information pharmacist or department that you're able to get in touch with, or you might have a medication safety pharmacist or medication safety team. And in general, we're quite nice, we're quite approachable, and we're usually, we're always willing to help. Hopefully, we're not always, we don't always have loads of time, but hopefully your pharmacists are always able to help you. So just good to find out wherever you're working, have you got someone that can if you need a bit of help with something, medicines, legislation, just find out who they are and maybe keep a note of their name and an email address if you need to get in touch with them. So find out what's available when you're wherever you're working. At Waitemata, we've got a, as Balaji will know well, we've got a controlled documents section on our intranet, and that's where we find all our policies and procedures. It's got a pretty dodgy search function, I have to say, but that's where we look if we wanted to find a standing order on something or a policy on something in particular. That's where we'd start, and hopefully we'd get there eventually. We've also got a page called CEDS, or Clinical Decision Support. Sorry, I've gone past that one now. Again, that's got information about medication, but it's also got information on different, you know, it's got palliative care on there, all different areas have got information. So that's what the Waitemata sites look like. I've just put counties and Auckland up there, so and these are accessible to everybody. So even in Waitemata, you can get onto the counties information or the Auckland information through the regional tabs. Counties in Auckland are slightly bigger than us, so they've got sort of quite fairly comprehensive medicines information pages, and you can see they've got things like you know, policies and procedures on the Paenui one, and on Auckland you've got medication bulletins, standing orders. So just really good places to go as a first port of call if you want some information, or if you can't find it, there'll be people to contact, and hopefully someone that does know, that you'll be able to find out on there. So final message, we are all human and we will make errors. We all will make errors in our professional lives, and as well as our personal lives, I'm sure. Speak up, log incidents, talk about the mistakes you made. We only learn from talking about it and sharing it. That's the only way that things change. So be part of a culture that, you know, if someone tells you they've made a mistake, you know, be supportive, be open, be honest, and be supportive, because we are, at the end of the day, we are all human. There's this term second victim, which you may have heard, which is when someone makes a mistake or makes an error, especially in the case that I talked to you about, the midazolam, where you can imagine that the nurse that gave that midazolam is what we call the second victim, so they need support as well. And actually, when you log an incident, that actually helps you get support, because that actually flags it up to the right people and makes sure that you or the person that did it is supported as well. And you know, that's very much in terms of making sure that you're okay to go back to work, to carry on looking after your patients as well. So that is something that that happens when errors are reported as well. And that's it. I think I finally talked myself hoarse. So if anybody's got any more questions, please feel free to ask them or type them now. But I also appreciate that it's Friday afternoon, so you are very welcome to get in touch with me directly or through Balaji if there's anything else I can do to help you. Oh, good, you are welcome.
Thank you, Lucy, and thank you for your time, and thank you for this session. It was very informative, as the attendees had commented. For the attendees, the PowerPoint presentation will be sent to you, as well as the recorded session will be available to you for you to, you know, review in future date. Yeah, that's all. Thank you, Lucy.
You are very welcome.
Have a lovely weekend.
And you don't
Long
get too
weekend.
wet.
No.
Thank you. Goodbye.
Bye-bye.